All right, well, my name is Dr. Chaudhry. I'm one of the psychiatrists. We'll have fun knowing about obsessive compulsive and related disorders. Who is not obsessive in this table? Before we start working here, um, Sven was very obsessively making sure the chairs are set up right, right? So we want to make sure everything is done absolutely right. So what is obsession?
An obsession can be recurrent or persistent thoughts or images that appear in the mind that become bothersome and the individual is unable to get rid of them.
Give us some examples.
So an example could be a disturbing thought about something violent happening to a family member or a loved one.
Okay, all right.
A fear.
A fear. And then give us some more examples of the commonly known obsessive kind of thoughts.
There could be obsessions about making sure, safety things. So turning off the stove, anxious thoughts.
Okay. What else? What are
Checking of locks.
Checking of locks, again, safety. So that's in the domain of safety kind of concern. Place is locked, I'm safe. Things about fire hazards and those kind of stuff. And what else people commonly worry about obsessionally?
Cleanliness.
Cleanliness, yeah, you get about 5 bonus points. All right, cleanliness, such as?
They keep on washing their hands again and again. They think that it's dirty, untidy.
Absolutely. So we kind of get into even though does the person know that the thought is real, or is it psychotic or delusional? What do you think about the thought?
The person may believe that it's unrealistic, but they cannot. The only way for them to control the obsessive thought is to do repetitive behaviors.
Okay, so the difference between obsessive compulsive disorder and psychotic disorders, and psychotic disorders people think their thoughts are real. But in an obsessive disorder they think it really isn't. But they still cannot stop doing that behavior. I have known of people, somebody who actually used to change his underwear 50 times, on, off, and miss the school bus. The parents didn't know what to do with that. I have known of people who would have a lot of sexually intrusive thoughts. I have a teacher who was in treatment, and she felt that for a 2-year-old young, that she might have sex with him. And it is such a disturbing thought, but it just keeps coming back. And she could not even share that with her husband, because she said, well, anyone who would know that a mother is having such thoughts would be so much, discredited for being a good mother. But yet it's not that she wants to have those thoughts, they just keep coming back up, right? So people can become very, uncomfortable even sharing their obsessive thoughts with other people. And then thus the distress and the inner difficulty that they have to endure. I remember many years ago when I saw someone who was churchgoer, absolutely a remarkable man, spotless history of being great, and then had a very honorable job. And he said he just had these thoughts that he may have sex with his nephew. And he goes, I cannot even begin to imagine how this thought could even occur in my mind. So for many months, he just was tormented by that, because he thought it's the devil and the thing and whatnot, But when he figured out all those kind of things, he just couldn't get rid of that. So he needed treatment. So many a times we have to treat these very serious psychiatric conditions. So tell us, what are the criteria to make the diagnosis for this condition?
Well, the individual must have either obsessions alone, compulsions alone, or both obsessions and compulsions. And they have to be time-consuming for the individual, so taking more than an hour a day. And they also cause significant impairment in the life of daily function for the person. And also, the obsessive-compulsive symptoms, they can't be attributed to any other substance or medication or another mental disorder.
Okay, so they're not due to somebody using cocaine or something else, and and that's not the way. One has to make sure it's not from that particular reason or a medical condition. So some medical conditions can actually create a similar, kind of a potential disorder. And how common is it?
In the United States, the 12-month prevalence is about 1.2%.
Okay.
And childhood onset is more common in young males.
Mm-hmm.
However, in adulthood, it's more common in females.
Okay. Okay. Now, you didn't tell me about compulsion. What does compulsion mean?
So compulsions, these would be either mental acts or actual physical acts that the individual will do to help themselves feel better about the obsessive thoughts. So this could be counting in their head or touching doorknobs a specific number of times, things like that.
Yeah. So I have an attorney who would call his parents over and over again and say, "Dad, are you okay?" And then Dad said, "I'm fine." And then 10 minutes later, "Dad, are you okay?" And it would drive parents crazy and drive himself crazy because he would call over and over again and say, "Well, I'm working. I'm working at Burlington factory. I cannot be called 1,000 times." It's very obsessive. And the idea is that maybe if I do it, I will be okay. But the brain doesn't rest. It just keeps on firing those thoughts over and over again. So our action do not take away the compulsion, the obsessive thoughts. So what are the risks and prognostic factors?
Well, the exact origin of the disorder isn't clearly understood, but there is believed to be a genetic component. So having a primary family member with OCD is a strong risk factor. And also the severity of the disease and its progress can be related to any comorbid conditions.
Okay.
And also if there is a specific traumatic event in young childhood that could precipitate onset.
Mm-hmm. So give us some clinical features that come with that.
So the patient could present with, as Dr. Hajar was saying, obsessions about cleaning or symmetrical.
Yeah, so let Dr. Hajar tell us more.
Mm-hmm.
It's more like a repetitive thing. They keep on doing it again and again, washing their hands again and again. Mm-hmm. And then if they're like obsessed about the security, they'll keep on checking the locks again and again. And that is like so disturbing that it impairs their daily functioning. So that's very common in them. And then they're like like checking their cupboards, putting their things in a stack, like in a particular manner. They're like particular about that. Then praying, counting things, silently repeating words again. So that's the features that are common in them. And if we want to differentiate it with other problems, then we can, like the diagnosis could be differentiated between anxiety, depression, eating psychotic disorders, like other mental disorders. We can differentiate it from.
So what's the difference between somebody who has obsessive compulsive personality versus obsessive compulsive disorder?
The main difference is that with obsessive compulsive personality, they have features of obsessions and compulsions, but it's not something that's significantly impacting their daily functioning, and it doesn't necessarily take more than an hour a day.
Okay. So most people with obsessive compulsive personalities actually can be very, very good in their fields. I have worked with an ENT surgeon who, to work with the ENT aspect of it's a small area to function, he's very meticulous in how he functions and operates. So he walked out of his home on a cold day and broke his hand by slipping on a thin sheet of ice outside of his garage. Now, the very thing that was helpful to him as a surgeon became a problem because he could not stand being not in operating room. And he wanted to make sure this heals fairly well. And he would take x-rays of his hand almost every day, off this elbow every day, and make a graph out of that and seeing how the healing is taking place. He was driving his orthopedic surgeon crazy. by kind of saying, oh, do you think it's healed now, or is it at that stage or not? He couldn't sleep. He was obsessing about his, healings and how long it might take. So the very obsessional quality that was helpful to him in his field became his detriment. Does that make sense? Okay. And most professionals are obsessive compulsive. So when we think about organizing things and putting things together, that's okay. It makes us better organized. It is when it goes beyond and becomes a dysfunction, then the dysfunction is causing the impairment of everyday living. And in psychiatry, every time it becomes a dysfunction, that's when we treat. If people can compensate, we are okay, right? Okay. And I just want to kind of highlight, in anxiety, depression, eating disorder, other kind of thing, people may do repetitive behaviors, but it may not necessarily be reaching to the highest degree of disorder. Most depression and anxiety conditions are not clean things. People obsess about things, and they worry about things, and that's not the same thing. So sometimes people worry about that, oh, I have obsessive compulsive disorder. It may not be that condition. Mm-hmm. All right. So let's pick maybe one or two in here. What's your favorite?
I would definitely go for body dysmorphic disorders.
Why?
Because it's like I've seen patients who have like preoccupation with one or more of their imagined perceived defects or flaws in their physical appearance which are not seen by other people. And at some point, these individuals perform repetitive behaviors like mirror checking, excessive grooming, skin picking, reassurance seeking, or mental acts like comparing themselves with other people. Mm-hmm. So in response to it's more like an appearance concern. And it is so obvious, and it's like disrupting their social and occupational and normal life functioning, and it is not better explained by any other mental illnesses. So that's the major criteria through which we can tell that this patient is suffering from a body dysmorphic disorder. And if you're looking for the prevalence in USA in adults, that would be like 2.4%. And it's more common in females than in males. Now, if we talk about the risk and their prognostic factors, usually they have like a childhood neglect or any abuse in their life that could lead to this thing. It is common in individuals who have like first degree relative with an OCDs. Mm-hmm. And if you look at males, they're more preoccupied with their genitals or muscle dysmorphy. And if in these kind of patients, suicidal ideation or attempts are higher in both adults as well as in children.
Fantastic. So let's kind of take a little shift. That's very good. How do we treat these conditions? I mean, I know that you have trichotillomania. Trichotillomania is a very fascinating condition. But we will just kind of look at, and we have people who have these conditions in our practice here. How do we treat with somebody who has something obsessional and related kind of disorder? How do we treat them?
Well, the most important treatment would be first the psychotherapy. I mean, they have to come up to the terms that this is like an obsession and they are like obsessing about something. So they have to have a therapy session with the psychotherapist.
Okay, so here's the therapist sitting here. What would you do if somebody shows up for you?
Well, there's a couple of things. I'll throw a fancy word out here, which I promise not to use again. And that would be collaborative empiricism, which would be developing a safe and trusting therapeutic alliance, a dialogue between the therapist and the patient, which identifies that dysfunctional thinking.
So hold your thought. Very good. Mm-hmm. You get out. Absolutely. Because without a trust, because if somebody has such difficult symptoms, how could they even begin to, the first few sessions are even meant to develop that, another human being knows that and does not discredits me. Because when some of those thoughts are kind of so disturbing or can be disturbing. So that's very well said. Absolutely remarkable to have another relationship where you can share all that's disturbing you. Fantastic. What else would you do?
Incorporation of dialectical behavioral skills into cognitive behavioral modification, which would involve First being present and aware through mindfulness, aware that these conditions, these repetitive, they're taking place. Then you would develop an internal dialogue to tell yourself what is going on and learning new skills such as being mindful and being aware and being present. And through some small changes lead to big ones, we would start identifying and self-validating when things go well.
Absolutely. So the thoughts are generated in actually, the scientists have figured out there's a part of the brain where those thoughts are obsessive compulsive disorder, the caudate nucleus of the, the head of the caudate nucleus, which fires off these, bad signals. It's almost like you are having a bad signal going on, like if you have something in the house and you start hearing the fire alarm, it just starts firing. And you have to figure it out. And many a time it may be a false fire alarm, something may have happened, but the cell may need to be, recharged. So we tell people the sciences of the brain, and then those thoughts have to be analyzed by the brain's frontal lobes so that, they're not quite taken very seriously, because these are just very goofy thoughts, don't have any merits, but they keep coming back up. It's almost like if somebody keeps knocking at your door, and it's almost like somebody calling you over and over again. And the telemarketer, would you pick up that phone again? You say, oh, it's them again. So you don't pick up that phone. But if you keep picking it up over and over again, then you're going to stay engaged in a very frustrating relationship. So we teach people other alternatives to do. Well, if you see a telemarketer calling and it's not a friend that you love, then don't pick up the call. And so those tools are taught by using the mindfulness techniques and tools and awareness and so forth. So what else? One more thing in regards to treatments. Not you.
It would be, sorry.
Okay, anybody. I know you are eager to share the next
It would be like if we see a sign of depression along with this, then we start them with a treatment like medical treatment, SSRIs for the depression.
Okay. You actually treat you treat them even if it's the OCD alone. SSRIs are the main treatment. SSRIs and the Prozac. Before all these things were developed, we had Anafranil was the only medicine that came in the market that was very effective for management of OCD. Before that, we really had very poor tools. So now we have very powerful tools, medicinally speaking, to reduce that brain's chatter. So it kind of, if you are developing 15,000 thoughts, maybe it'll drop it down to 2,000. So there's less thoughts which are being generated, and then the ideas of therapies can become more meaningful, because if your brain is so busy chattering back and forth that you just cannot do that. So medicines are a very integral part of this whole thing. One more thing, so we talked about medicine, we talked about the therapies. What else we need to do to help people? Jim?
I would ask you.
Isn't that interesting? Psychosocial supports, so always treatments are lined up in three: medicational supports, sports by therapies. Psychosocial supports are, a person's wife may be on the edge of saying, well, I'm just going to leave him. I just can't stand the way he is or she is, vice versa. Difficulties in relationships arise out of the OCD thing. I actually have a patient whose husband is going through severe OCD, and she's up to here because she does not know what to do with him. He would refuse going to the hospital. He refused to go to the different places, where he can get better. So helping them understand the disease and disorders, because it's no different than diabetes or hypertension or anything else, these conditions can take toll on people's lives in the other way. They may not be able to function well. So you help their employers to get to know, oh, well, I have, so in treatment, but they are going to, in time, return to work after their symptoms are better controlled. Right? So psychosocial supports are very important. So that really kind of concludes our OCD. So don't be a hostage to OCD if these symptoms were to arrive, but recognize there are very effective managements, but it has to be done with a scientific methodology and understanding, so they're done right. So at CClear, we offer not only medicinal treatment, but we also offer therapeutic interactions with clinicians who know what to do, and also provide the psychosocial support and the skills of mindfulness, along with using the nutritional and life-changing medicines. So these treatments are very effective, and they work very well. People get their lives back, and actually the teacher and the other people that I've talked about, most people who got engaged in treatment have a very fulfilling and rich life. So it should not be like diabetes or hypertension. We should not be hostage to that. We can take care of the treatments and then have our lives back. So that's that. We have one more subtopic today. Today the psychiatric special. It's a blue light special. We thought we'll do a little subtopic, and that's forensic psychiatry. The reason I testified in a murder case just 2 weeks ago approximately, and it made me think about forensic psychiatry and its implication on people's life, and how it can be very, very struggling. So today we'll just do an introduction, and maybe the next time we will get into a bit more of a law, its impact in everyday life. But today is an introduction and a teaser for the future topic. For the teaser, we have a teasing idea here. You want to tell us a bit about what is forensic psychiatry?
Forensic psychiatry is a branch of medicine which focuses on the interface of law and mental health. It may include psychiatric consultations in a wide variety of legal matters, such as an expert testimonial, as well as clinical work with perpetrators and victims.
Okay, so what's the difference between civil law and the criminal laws? You want to tell us about that?
So civil law, psychiatrists and other mental health specialists are often required to conduct assessments with a view to determine the presence of mental or emotional problems in one of the other parties, such as the victim or the perpetrator.
Okay, so I'll give an example. I have a nurse whose mother, she is the guardian, she is the power of attorney for her mother, and her other family members are intervening and saying, well, we don't want her to be treated like this. And they want to take her out of that nursing home, bring her home, and she feels that she's at risk for fall and a risk for eating improperly and thus risk for having pneumonia. Then she feels a bad idea to take her away from nursing home, whereas other family members are contesting. So it's now going to a legal place where somebody has to see what's mother's desires and who decides what to proceed. And actually just last week she was asking my opinion about that. What if the mother wanted her to be a power of attorney, say, a year ago, and now mother has dementia? How do we manage what to do? So these become very everyday living things. So civil law is really developing competencies, determining a person's capacity. If they have previously made if I had made a decision to not have me resuscitated in the hospital, and I'm in a car accident, and my wife comes in and says, I want to do everything to save his life, who should be honored? What do you do? I may have a living will, and my wife is a living person. How do we decide? How do we manage these kind of complex psychosocial issues? So it's a civil law which manages those civil matters. So what's the criminal law?
So criminal law verifies the fitness to stand trial, and insanity regulations, and dangerousness application.
Okay. All right. So the person that I was talking about, this was a guy who in a prison had a cellmate and killed his cellmate. And so I was asked to do a determination of his competency, whether when he acted on his impulse to kill his cellmate, whether he was whether he was with a disease of mind that caused him to not know from right from wrong. And it's a very difficult situation because you have to go back in time like a couple of years and try to build the pieces of the puzzle. What was he like at that time? So I had to look at all the evidence of his tape recorded information, his interview, the evidence of the photographs of the cell and everything, and then see if he really qualified for a psychiatric condition. Now, having a psychiatric condition does not qualify as an easy ride, that you say, well, if I'm schizophrenia or I am diabetic or something else, that it means that you automatically you get a free ride to from. It's not that we have to differentiate between, the conditions and its implications and whatnot. Very interesting situation. So we do competencies in that as well. So today our goal was to introduce this thing, and maybe we'll have another conversation about this thing in future. These would be available on our website for people to review. Again, these are weekly sessions of education of common conditions, their potential treatments, and hope for us to find our way and our way back to life. These girls did an absolutely remarkable job of doing this preparation of these articles. Wouldn't you say so?
Yes.
Isn't that remarkable to get them? So thank you all for your attention, and here we conclude this one. And next time maybe we'll do which topic?
I would definitely want to do the post-traumatic distress.
Post-traumatic stress disorder. That's our topic for future, and then maybe we'll do. You can become a forensic psychiatry expert, and maybe do one more layer to that next time. So we'll have a special next week as well. Thank you all.